Chronic hepatitis. Definition. Chronic hepatitis is defined as a hepatic inflammatory process that fails to resolve after 6 months. Etiologies. 1. Except HAV and HEV, all hepatitis viruses can cause chronic hepatitis. 2. Other causes. A. Drugs like methyldopa. B. Autoimmune disorders. C. Idiopathic causes. Pathological classification. Please don't forget to subscribe to our YouTube channel. 1. Chronic persistent hepatitis, inflammatory activity is confined to portal areas. 2. Chronic lobular hepatitis Omicron inflammatory activity and necrosis are scattered throughout the lobule. Omicron-limiting plates of periportal hepatocytes are intact and no periportal fibrosis. 3. Chronic active hepatitis. Inflammatory activity in portal areas spills out into the lobule, periportal hepatitis, piecemeal necrosis, in association with necrosis and fibrosis. Thought to have a significant risk for progression to cirrhosis and hepatic failure. Medical therapy. Somatostatin, or octreotide, reduces splanchnic blood pressure when given intravenously. Vasopressin with nitroglycerin help to minimize systemic vasoconstriction. Endoscopic therapy includes injection of sclerosing agent and/or band ligation of varices. Balloon tamponade. Compressing bleeding varices temporarily surgery. Portosystemic shunt prevention of variceal hemorrhage. The following drugs can be given for patients diagnosed to have CLD. They are not given during active variceal bleeding. Non-selective beta blockers, propranolol and nadolol. Mononitrates. Isosorbide mononitrate, decrease portal blood flow and pressure. 3. Ascites. Transidative. Serum to acidic albumin gradient is greater than 1.1. Clinically detectable when larger than 500 milliliters. Most sensitive clinical sign is shifting dullness. Subclinical ascites can be detected by ultrasound examination. Management of ascites. Salt restriction to less than 2 grams per day. Fluid restriction if serum Na+ level is below 120 meq/L. Spironolactone, aldactone, is an aldosterone antagonist, is often effective when given with loop diuretics. Diuresis should be monitored because vigorous diuresis leads to hypovolemia and hypokalemia and precipitate hepatic encephalopathy. The goal of diuresis should be dependent on the extent of edema and be monitored by daily body weight measurement, i.e. O decrease weight by 0.5 kg per day if no peripheral edema and O decrease weight by 1 kg per day if peripheral edema is present. Refractory ascites is defined as persistent tense ascites despite maximal diuretic therapy, spironolactone 400 mg d, furosemide 160 mg d, or if azotemia develops, creatinine greater than 2 mg per deciliter, while the patient is receiving sub-maximal doses. Chronic viral hepatitis complicates about 1% of acute hepatitis B, young, immunocompetent, and 85 to 90% of acute hepatitis C will develop chronic hepatitis. About 20% of the later will develop cirrhosis in 10 to 20 years. Subjects with either HBV or HCV infection have greater risk of developing hepatocellular carcinoma. Treatment can suppress hepatic inflammatory activity in 30 to 40%. Hepatitis B. Therapy is indicated for patients positive for HBs AG and HBC AG, high replicative phase. Treat with interferon alpha and lamivudine. Hepatitis C can be treated with interferon alpha and ribavirin. B. Cirrhosis of the liver and its complications. It is the end result of fibrous scarring and hepatocellular regeneration that constitute the major responses of the liver to a variety of long-standing inflammatory, toxic, metabolic and congestive insults. The normal hepatic lobular architecture is replaced by interconnecting bands of fibrous tissue surrounding nodules derived from foci of regenerating hepatocytes. The following pathologic changes are the cause of the clinical manifestations and complications of cirrhosis. 1. Fibrous scarring and disruption of hepatic architecture distort vascular bed leading to portal hypertension and intrahepatic shunting. 2. Disturbed hepatocellular function. Clinical and laboratory features resulting from hepatocellular dysfunction. 1. Hypoalbuminemia. 2. Decreased coagulation factors resulting in prolonged prothrombin time. 3. Hyperbilirubinemia. 4. Increased blood ammonia level. 5. Hepatic encephalopathy. 6. Ascites portal HTN. 7. Ascites. It occurs in 10% of ascites of CLD origin. Such patients should be referred to hospitals for treatment. Repeated large volume paracentesis, with intravenous albumin replacement if available. But the following two modalities of therapy are available in developed countries. Surgical treatment, portosystemic shunt, liver transplantation. Complications of ascites. Omicron spontaneous bacterial peritonitis. Omicron hepatopulmonary syndrome. Omicron hepatorenal syndrome. Omicron rupture of the umbilicus. A. Spontaneous bacterial peritonitis, SBP. Usually due to Enterobacteriaceae or pneumococci. Characterized by fever, abdominal pain and tenderness. Hepatic encephalopathy may be precipitated by the infection. Diagnosis is suspected when acidic polymorphonuclear cell count is over 250 per microliters. And confirmed by acidic fluid culture. Treatment is with third-generation cephalosporin for 5 to 7 days. Prophylaxis for SBP indications. Previous history of SBP. Patient admitted with gastrointestinal hemorrhages. Acidic protein less than 1 gm per deciliter. Candidates of liver transplantation drugs. Norfloxacin 400 mg per day. Ciprofloxacin 750 mg once weekly or co-trimoxazole 960 mg d for 5 days, Monday to Friday. B. Hepatorenal syndrome, hours. Functional renal failure in the presence of varices. Splenomegaly causing thrombocytopenia and leukopenia. Hepatic encephalopathy. Major causes of cirrhosis. 1. Alcohol and HCV are major causes in Western world. 2. HBV is the commonest cause in developing countries. 3. Other causes include biliary obstruction, intrahepatic and extrahepatic, leading to biliary cirrhosis. Autoimmune hepatitis. Major complications of cirrhosis. 1. Portal hypertension, HPN. Normal portal pressure gradient 10 to 15 centimeters of saline. Portal hypertension is said to exist when the portal pressure gradient is over 30 centimeters of saline. Portal hypertension leads to the formation of venous collateral vessels between the portal and systemic circulation. Collateral vessels may form at several sites, the most important clinically being those connecting the portal vein to the azygous vein that form dilated, tortuous veins, varices, in the submucosa of the gastric fundus and esophagus. Types of portal hypertension. I. Presinusoidal portal HPN. Increased resistance to portal blood flow into the liver, e.g. schistosomiasis, causes periportal fibrosis and presinusoidal portal HPN. E. Sinusoidal portal HPN is the commonest and found in cirrhosis. The resistance is in the sinusoids of the liver. E. Post-sinusoidal portal HPN. Increased resistance to hepatic venous outflow from the liver and causes include hepatic vein thrombosis and congestive heart failure. 2. Variceal hemorrhage. Esophageal varices has a mortality of 30 to 60% if it bleeds. May present with hematemesis, melena, hematochezia. Treatment of variceal hemorrhage depends on the speed and volume of bleeding. Acutely bleeding patients should be referred to hospitals for intensive care. Resuscitation. Omicron mercaptans, a cause of fetor hepaticus in CLD. Omicron short-chain fatty acids. Clinical features may involve disturbance of higher neurologic function, intellectual and personality disorder, dementia, inability to copy simple diagrams, constructional apraxia, disturbance of consciousness, disturbance of neuromuscular function, asterixis, hyperreflexia, myoclonus. The findings are usually asymmetrical, but can also be symmetrical. The manifestations depend on the stage of hepatic encephalopathy. Treatment of chronic hepatic failure is based on 4 principles. 1. Identify and treat precipitating factors including GI bleeding, increased dietary protein, constipation, alkalosis, hypovolemia, infection, azotemia, hypokalemia from overduresis, CNS depressant drugs. 2. Reduce and eliminate substrates for the generation of nitrogenous compounds. Restrict dietary protein. Omicron for patients in coma. No protein should be given. Omicron for non-comatose patients. Restriction of protein to 40 to 60 g/d is enough. Cleanse the bowel with enema in patient with gastrointestinal hemorrhage. 3. Reduce colonic bacteria that generate ammonia using oral preparations of neomycin or metronidazole. 4. Prevent diffusion of ammonia from the bowel lumen to the blood by administering oral lactulose, lactitol, or lactose, in lactase-deficient patients, all of which are fermented by colonic bacteria to organic acids and reduce stool pH. The hydrogen ion produced traps ammonia in the colon and changes it to non-diffusible NH4+ ions. Hepatopulmonary syndrome, characterized by abnormal arterial oxygenation in a patient with cirrhosis and/or portal HTN. Pathogenesis is thought to be due to intrapulmonary vasodilatation leading to impaired O2 transfer that improves with 100% O2. Clinical features range from subclinical abnormalities in gas exchange to profound hypoxemia causing dyspnea at rest. It is a functional disorder that reverses with liver transplantation. Occurs when there is significant hepatic synthetic dysfunction and severe ascites. Vigorous diuresis, paracentesis and sepsis may predispose to ours. Typically the kidneys are histologically normal with the capacity of regaining normal function in the event of recovery of liver function. There is severe cortical vasoconstriction. Characterized by declining GFR, oliguria, low urine sodium, less than 10 mg, L. Normal urinary sediment and azotemia often with disproportionately high levels of blood urea nitrogen and creatinine. Diagnosed after prerenal cause of renal failure is excluded. Mortality rate from hours is 95%. Management of hours. Volume expansion to rule out volume depletion. Low-dose vasopressin, octreotide or norepinephrine may be given. Liver transplantation is the accepted management. 4. Hepatic encephalopathy, hepatic coma or portosystemic encephalopathy. It is a complex neuropsychiatric syndrome that may complicate advanced liver disease and/or extensive portosystemic shunt. It manifests in two major forms, acute and chronic. Acute minus occurs in the setting of fulminant hepatitis. Minus cerebral edema plays a more important role. Minus mortality rate is very high. Chronic minus occurs in chronic liver disease. Minus often reversible pathogenesis. Minus the hepatocellular dysfunction and portosystemic shunt leads to inadequate removal of nitrogenous compounds and toxins ingested or produced in the gastrointestinal tract, getting access to the brain and causing hepatic encephalopathy. Minus the compounds commonly incriminated in causing hepatic encephalopathy include 1. Ammonia is very well known and studied. 2. GABA. Minus discourage alcohol, restrict sodium. Minus high calorie, high proteins when encephalopathy isn't present. High vitamins. Low fat if cholestasis is a feature. Minus when neurological disturbances and elevation of blood anemia are features. Eliminate protein from the diet and maintain PT on carbohydrate. Summary. Minus liver cirrhosis is chronic degenerative disease of the liver. Minus the cells are damaged. Minus fibrosis and regeneration nodules overwhelm the liver. Minus caused by alcohol, drugs, chronic active hepatitis, cholestasis, immunologic and metabolic disorders. Minus it's characterized by jaundice, edema, ascites, anemia, spider angiomas etc. Minus may lead to hepatic coma, portal hypertension, bleeding esophagogastric varices, anemia and increased susceptibility to infections. Minus investigated and diagnosed through history, physical exam, liver function test shows elevated ALT, AST, reduced serum albumin etc. Minus treatment. No treatment can reverse cirrhosis or even prevent further progression. The principle of therapy is to promote and improve general health and alleviate symptoms by correcting malnutrition, control fluid retention, encephalopathy and alimentary bleeding. Thanks for watch. Please don't forget to subscribe to our YouTube channel.